Hello, everybody. My name is Jan de Waele. I work at the Ghent University Hospital in Ghent, Belgium. And today I will be discussing antibiotic de-escalation and particularly focus on how to do it in your ICU. These are my disclosures. Antibiotic de-escalation is an integral part of antimicrobial stewardship. Antimicrobial stewardship is actually a set of interventions aimed at reducing antimicrobial resistance and improving outcomes. So when looking at a whole course of antimicrobial therapy, a typical course of antimicrobial therapy, there are in fact a number of opportunities along the road to optimize therapy. Of course, it starts at the beginning with the correct diagnosis and the correct choice of antimicrobials. And during therapy, there's in fact a window of opportunity to de-escalate and change the empirical choices you have made in order to reduce antimicrobial resistance. In every antimicrobial course, we shouldn't forget about the duration of therapy. So also at the end of treatment, that's a very important time point for me. And avoiding long antibiotic treatments is certainly a goal of treatment as well. So what is the goal in antibiotic de-escalation? Well, less is more. Again, it's about decreasing the side effects. The more antibiotics, the more toxic antibiotics we would administer, the more side effects we have. And costs, well, this is a no-brainer as well. If we give a lot of antibiotics, particularly the newer and more costly antibiotics, reducing the number of antibiotics will certainly be a cost-saving thing as well. But probably the most compelling reasons why people would de-escalate and why antimicrobial stewardship is being practiced around the world, it's not so much about the side effects and the cost, it's about reducing antimicrobial resistance, which is, of course, an ever-present thing in all of our ICUs. But let's get back to antimicrobial de-escalation. And let's for a minute look at the evidence. What do we know about antibiotic de-escalation that can help us to implement it in our clinical practice? So I would like to share some data with you that come from the Diana study. It's a study we did through the European Society of Intensive Care Medicine, and that focused on antimicrobial use as well as de-escalation in empirical therapy. So this gave us information of about 1,500 patients from different centers around the world, with a lot of patients who received combination therapy, a lot of patients who received carbapenems or broad-spectrum beta-lactam antibiotics. As in other infection reports, just over half of the infections were microbiologically confirmed, but all of them were clinically confirmed infections. One of the important conclusions and important findings of this study was that antibiotic de-escalation within 72 hours, because this is what we consider to be the golden hour of de-escalation, was done only in 16%. So that means only 1 out of 6 patients in whom broad-spectrum antimicrobial therapy started for an infection actually has their regimen changed within the first 3 days. This was mainly discontinuation of combination therapy. So if you start 2 or 3 or 4 antibiotics, you drop at least one of these antibiotics. And only in 1 out of 3 of the patients who were de-escalated, it was only about narrowing the spectrum of the antibiotic. 30% of the patients had both discontinuation of combination therapy as well as narrowing the spectrum. But still, this was a surprising finding that only 1 out of 6 patients actually was de-escalated. Again, with a lot of patients receiving combination therapy and broad-spectrum antibiotics. Not surprisingly, there was more de-escalation in patients who received combination therapy, in patients with septic shock, in patients in whom microbiologically confirmation was present, and in patients who needed source control. These are the crude numbers of clinical cure, no difference there, and when correcting for disease severity, inappropriate therapy, and multi-drug resistant colonization, we found actually antimicrobial de-escalation to be not worse compared to no de-escalation. So from the study, we concluded that as it is applied, antibiotic de-escalation seems to be safe, albeit a quite rare finding in our ICUs. So how can we implement de-escalation in our units. This is a 5-step approach I'd like to discuss with you. The first step actually is done before you are doing any actual de-escalation. It's about agreeing within the stewardship team on a definition and identify for your unit, for your hospital, specific targets that require more attention. So de-escalation, when you look at the literature, is defined as narrowing the spectrum, decreasing the number of antibiotics, and I mentioned this already, but also in the literature, some studies included shortening the treatment as de-escalation, which a expert group later considered not to be part of de-escalation. So pure de-escalation is either narrowing the spectrum or decreasing the number, and this is very important to agree on upfront. The big challenge, however, is ranking antimicrobials. And this is one attempt that was done to rank beta-lactam antibiotics using a Delphi approach, and it needed quite a few rounds before consensus was reached, as you can see here, with amoxicillin being the lowest rank and the carbapenems being having the biggest effect. So not really surprising, but the problem is that, of course, this is limited to beta-lactam antibiotics as well, whereas we use a lot of other antibiotics. I do want to mention this other study that for every antimicrobial, based on its spectrum, calculated a spectrum score. So this allows you to combine different antibiotics, calculate the total spectrum score, and see if there's any opportunity for de-escalation. For instance, this example, when you go from moxifloxacin to ceftriaxone, you can see that actually this is a step from 36 to 25. So this would be de-escalation, whereas going from vancomycin to trimethoprim sulfamethoxazole would actually be the opposite, would be escalation, because you go from 13 to 40. And so for every combination, you can actually calculate the spectrum score and check if this is really de-escalation. Now, a lot of de-escalation definition, of course, is generated within your own unit and hospital. And I think it's very important to review your prescription practices, because there's habits in every hospital, in every unit. There's preferred antibiotics, there's antibiotics that may be on the formulary and others that may not be. And depending on your prescription habits, I think it's important to identify areas where you may be overusing particular antibiotics more than other units. So identifying these primary targets is very important. Check, of course, your empirical choices in the local formulary to see what other options that are available, and then agree on a number of predefined changes in spectrum that can be applied probably as a routine in the majority of the patients. So that will be helpful to implement this at the bedside. Now, next, of course, it's important to collect the information that is necessary to de-escalate. And what does this mean? You need, of course, to confirm that actually an infection is present. This is quite logical. The next step is to have a pathogen identified as well as its susceptibility. So these are important things. Now, it doesn't really stop there. There's also an opportunity to use information that is not there to help de-escalation. And I will give you an example. If, for instance, you've started vancomycin because you are concerned that there could be MRSA involved in infection, the fact that MRSA is not found by the lab can also help you to de-escalate and to just drop the vancomycin therapy. So always look beyond what is found and what is reported. Now, logically, this is a time-sensitive issue. We want to de-escalate as soon as possible. There's no use, if you're looking at a 7-day treatment on de-escalating, there's no use of de-escalating on day 5 or day 6, because that will leave you only 1 of 2 days with de-escalated therapy. So this is where rapid diagnostics may have a role. When you look at the time you need to get a culture and a susceptibility using the culture-based techniques, it can take up to 3 days. 2 or 3 days would be typical. But other techniques such as Malditov will give you an ID, and in some cases also susceptibility, much more quicker. And this may absolutely contribute to an efficient de-escalation strategy. Communication is, of course, very important. Communication with the lab. It should be direct. And when I mention communication, it's not only about the lab informing you about the results, but also vice versa. It's important to talk to the microbiologist When I have the habit of directly calling the microbiologist if we have a challenging patient, specific situation where we want, for instance, to have already a direct examination or other specific tests being ordered. So it's not only getting information from the lab, it's important you provide the lab with adequate information as well. And this should be complemented, I think, with regular physical meetings. This gives me the opportunity just to reinforce the concept of an antibiotic stewardship teams where different specialties, different backgrounds contribute to an optimized antimicrobial use. And absolutely, this de-escalation is something that really fits in a modern antibiotic stewardship approach. Final two steps. Well, the next step is maximizing antimicrobial de-escalation. As I've told you, it's about narrowing the spectrum and decreasing the number, but you shouldn't be satisfied by just doing one thing. If there's an opportunity to go from 3 antibiotics to 1, well, do so. If there's an opportunity to go from 3 antibiotics to 1 narrow spectrum antibiotic, that's an even better opportunity. So maximizing de-escalation is something to be considered. How do we fit this in the whole approach? After starting empirical therapy, at some point in time, we will have information of the pathogen and susceptibility, and you will also have observed the clinical response of the patient. And this gives you the opportunity to reevaluate. And at this reevaluation, and this shouldn't necessarily be one single point in time, this can be a repeated reevaluation at each time point when new information comes in. It's the time to check your antibiotic treatment and to stop at first unnecessary antibiotics or combination therapy. If you're giving 2 drugs for one pathogen, the majority of the cases that is not necessary and one of them can be stopped. If you have a full information about the pathogen, then it may depend on the duration, the projected duration of therapy. If you're going for a short course, 5 days, fewer than 5 days, and I think 1 or 2 days of change therapy will probably not have a huge effect on antimicrobial resistance. But when you're going for long courses, 5 to 10 days or even longer, then absolutely this is an opportunity to narrow the spectrum of the antimicrobial. And the last and also important step, it's beyond the escalation, but it's about predefining the duration of your antibiotic therapy. At that point, it's important to say we should be giving this antibiotic for another 5 days. If the patient is discharged to another ward, also give this information to your colleagues who take over the care for this patient. So yes, we can do it. We should be doing it more. Remember, only 1 out of 6 patients on average, and I'm sure that you will be doing much better in your ICU, but probably even you can do even better. It will take effort and it takes a lot of communication and a lot of interaction with other people. But the important thing is to realize that antimicrobials do have side effects and we have to do anything we can to reduce this. So in conclusion, I think the current evidence clearly shows us that antibiotic de-escalation is safe and it reduces antimicrobial exposure. And I think it's imperative it should be considered in every antimicrobial course that is initiated in the ICU. I think there's a lot of opportunities that you can identify yourself in your unit, but it's important to make sure that you will have all the information required. And at the beginning of treatment, to do adequate microbiological sampling and communicate with the lab at every stage of this process. Early de-escalation is absolutely better than late, and we should be very careful not to prolong our antimicrobial therapy by de-escalating, because that's what a lot of studies have suggested in the past. And with this, I would like to thank you for your attention and end my presentation.